world. Thank you for joining us for our first session today with a very special guest. You're honored to have her, Dr. Henriette Lerner, hosted by Dr. Joseph Mina Atala. Thank you for joining us today.
Thank you so much for this great opportunity to be here and to spread virtual information and knowledge. Chapeau to your great activity internationally, Piano.
Thank you, Dr. Lerner.
Dr. Lerner, go ahead, Dasha.
I was going to do a couple of housekeeping things. Today, we are reaching over 700,000 of our colleagues from all the countries of the world, all the continents of the world. And we have 15 more days of very exciting presentations to come by some of the most well-known leaders in dentistry. And we hope that you can join us. A little bit of my interaction with Dr. Lerner. She is an icon, an idol in dentistry, known and loved by many across the world for all of her initiatives, be it the Digital Dentistry Society, be it the Leading Ladies in Dentistry, be it her lovely communications in 7 different languages that she speaks. And on her resume goes. We probably won't have enough time to go over her entire resume today, but Dr. Atala will try to give you guys a brief bio. With that said, you have the floor, Dr. Atala.
Good morning, everyone. Dr. Lerner, we're very honored to have you today, and we're very excited about your presentations. It's an honor. I'm going to give a little bit about the background of Dr. Henriette Lerner. It's just a little bit of what your accomplishments are, but just to give everyone an idea. Dr. Henriette is a medic. Lerner motto in aesthetic is a way of life, a specialist in oral surgery focusing on implantology and aesthetic. She's an educator in the topics of implant dentistry and grafting techniques and digital technology, as well as the aesthetics on implants based in Baden-Baden, Germany. Dr. Lerner graduated from the University of Medicine, Faculty of Dentistry, Timisoara, Romania, and finished her surgical and implantology education in Germany and the United States. Dr. Henriette Lerner is the founder and director of HL Dental Clinic and Academy in Baden-Baden, Germany, which is an academic clinical teaching and research facility of the Johann Wolfgang Goethe University in Frankfurt on Main, Germany. He serves as a board member and expert of the DGOI, the German Society for Oral Implantology, and is currently the president of the Digital Dentistry Society International. Dr. Lerner is an editorial advisor for 3 scientific journals, Practical Implantology, DGOI, Oral Implantology, and MDPI. He's the author of a number of scientific papers and book chapters, Aesthetics in Dentistry, Implant Aesthetics, Digital Occlusion Implant Rehabilitation, which detail aesthetics in implantology, grafting procedures, biomaterial sciences, and digital technology. She has contributed to the development of implant systems, dental apps, and surgical instruments. What an honor, Doctor. We're happy to have you, and we're very excited about today.
Thank you so much for that much too long introduction. Thank you so much.
This is nothing to what you actually achieved. So this is just a summary.
Okay. So hello, everybody, and I'm glad that you're online. What a fascinating world where we are able to talk on this wave, on this virtual wave. Actually, it was meant to come soon, that virtual education, right? But now it started sooner than we expected, and all the bad things had a little good one in it, right? I will start with a little music, and I will get then back to my slides. Okay, So actually my topic today is contemporary digital implant dentistry science and clinics. I would like to go with you through an overview of the digital workflow, what we know, where we are, what we know, what we don't know, which are the parameters which make our digital work and workflow predictable, and what we still don't know, what is coming. Talking about aesthetic and implant dentistry, we are aware from the literature of many parameters which we respect in the freehand implant placement, in the freehand surgery. And we defined parameters of aesthetics around implants in freehand surgery. Using these parameters, we see that the success of the reconstruction in full arch rehabilitation, mostly in immediate placement, immediate loading procedure, have a high success of the osseointegration and also a high aesthetic success, even though we are starting our treatment in extremely compromised, bony, soft tissue situations. We build up natural looking teeth on implants using parameters of implant design, of implant position, of the crown design and abutment design, trying to give the best aesthetic possible. Nevertheless, in the last 10 years, we switched and we moved slowly, or even faster, from the freehand navigation to the static navigation or even dynamic navigation, to the digital planning of implants and the digitalization of all of the steps in dentistry. And this is actually a revolution. It's actually a new discipline which we are working on today, and that is why it is needed a new Bible, a new book, a new parameters where we are working. Because except of the parameters which we know and which we of course apply in the digital workflow, we have the parameters of accuracy, trueness, precision of the different technologies which we use. On the other hand, we have the accuracy of the matching of different technologies and bringing them in a coherent workflow in order to give a more accurate result, a more precise result, a more aesthetic result. At least this is what we hope, because otherwise we would we don't have the reason to go to the digital workflow. So we hope and we aim to a more minimally invasive procedure, to a higher precision of the manufacturing, of the planning, of the surgery itself, to a better aesthetic and functional outcome, to a higher predictability and a reduced time of treatment. And we all know, which we're working in a digital field, that the time of the preparation, the time of the planning is longer, more sophisticated, is a completely other workflow, whereas the surgery itself, the manufacturing itself is shorter. So placing all these cases of full arch rehabilitation, and a couple of them you will see in the presentation, in a study, we see that in the digital workflow, we have a high success of the osseointegration. This is an article which we published recently in the BMC Oral Health with Professor Sada and Ganati and Uli Hauschild, which is the master technician which helped in the work with us in the workflow. The static navigation has or can be split in these 4 big chapters: scan, plan, make, done. Scan, meaning all the digital data which we can acquire from the patient, beginning with the face, the teeth, videos, the intraoral aspect of the tissues through intraoral scanning or lab scanning, an occlusal analysis, which would be also done in the first stage, digital virtual registration of the movements of the jaw, and a DICOM data. So all these are scanning or are belonging to the scan procedure. And you for sure will have or had the lecture of Milos, who teaches you to do great photos in a very simple way. We work today the planning, of course, with a cone beam CT. Is no other way to plan a case digitally on implants. And the criteria of choosing these technologies are to be very carefully done, meaning it has to be a technology which gives you a great artifact reduction, low dose capabilities. And I'm sure, and you see it coming, that we will work only with 3D devices and not with 2D, because we work 3D, so it's normal, because the dosage, the dose will be lower and lower. Now, we have to be able to have multiple fields of view. We have to have a high accuracy of the images and a good positioning of the patient, because you know that the first inaccuracy are starting there. We use the intraoral scanners, which have the highest trueness, precision, and accuracy. And that is why we go from study to study, and we implement the newer technologies into the studies, judging and studying and evaluating the accuracy of these devices. Going back for a minute, I can just mention that state of the art is that the intraoral scanners are, most of them individually, but most of them accurate for the images of single tooth and teeth on implants, and also bridges. But in full arch reconstructions, the intraoral scanner is not offering that accuracy which we expect. Registering of the function. This is a device, a technology which is really giving us and helping us to get rid of the bite registration and the face fold. Registering the initial movements of the jaw, being able to increase the occlusal vertical dimension with maintaining the frame of the movement is an extremely precious virtual data, which we transport then to the provisional restoration, to the final restoration, and we maintain it. So since then, we don't have the occlusal problems, the movement problems, which we had before. The occlusion registration with the help of a sensor, with a sensor-based technology, is a technology sine qua non. That means it's no way to adjust the bite on implants with the necessary precision without using a more accurate technology than the blue paper. And I will talk about that a little bit later. The visualization of the plan is the second stage, second chapter of our workflow. It's including the planning of the smile, 2D and 3D. So beginning with the photos, we started to, with the help of a keynote, to build up in a 2D manner the smile of the patient. Nevertheless, the technologies are helping us today to visualize it automatically with some technologies, or even to use artificial intelligence, which is technology is so fascinating, and it's it's coming in every step of our digital workflow more and more. You are able to do, with the help of artificial intelligence, the dynamic modification of the teeth on a spot. Plan means also planning of the 3D teeth in different softwares of planning and planning the guide, matching the cone beam CT with the STL file of the 3D visualized teeth. We have the base for the planning of the implant, of the bone, of the treatment, surgical treatment as such. The fourth step of the planning is the planning of the provisional in an immediate placement, immediate loading procedure. The artificial intelligence is interfering here too in the planning by being able to determine the nerve. In the future also, we are able to place the implant with a button. So society is working on that. The third stage is the manufacturing through printing and milling procedure. So milling is one very good established procedure. Nevertheless, the printing is the future milling. And we print the models, we print the guides, different styles of guides, and even the provisionals. Nevertheless, the accuracy of the guides is depending on the accuracy of the printers. And one of the newest articles published together with Francesco Mangano, Davide Faronato, Matteo Bonaccina shows the differences between 6 different printers, desktop printers. The study is including a prototype, geometrical form of a parallelepiped, but also orthodontic virtual data, which were printed with the 6 printers. And we can see that there are differences in the linear measurements and the amplitude between different desktop scanners, and also diameter differences, very individual. And those individualities are coming from it's more studies needed to have more details about the printers. The reality is the different technologies of stereolithographic or even optical based on light technology have different results, and also the materials, which are very differently used, give differences in the results. More than that, we matched then the virtual data of the final model with the original virtual data, and we saw after a month that of the laying of the models that the trueness was low. That means that the 3D printed models may undergo some dimensional contraction. So that was the second conclusion of the study. So very careful with the printers too. So we have all this accuracy testing necessity, and also the matching of one technology to the others, to see and to realize that in the surgical procedure you have you want to have a high accuracy from the planning to the final result, but you have also not the accuracy not the precision that we think that we have, even in the positioning of the implants, which is an issue that we have to take care in the planning. We have a distortion, a discrepancy of the color or the apex of implant, depending on the study that you read, between 0.7 and 0.8. So, which is essential. This is important in the surgery. This is one of the studies of the digital accuracy in one of the workflows. So I will go with you through some of the cases from simple to more complex, and with different guides, different workflows matched together using all these new technologies and following the 4 steps of the workflow, and discuss with you or present you the different parameters which we used in order to get a good aesthetic, and also the differences between the individual differences between the workflows. Now, this is a very simple case of a missing frontal tooth by an accident. The soft tissue was missing more than the bone, and we took a connective tissue graft. We had then a nice soft tissue situation, which we could deal with by digital planning of the implant. Then we had this aspect of the soft tissue, which we always need to reach, and we will discuss about that later on, that 3 millimeters necessary to have in order to have papillas between teeth and implants. We use, of course, implants with platform switching design in order not to lose bone or only 0.6 millimeter of bone. We use methods to increase the soft tissue thickness and the dimension of the supra or the supracrestal fibers in order to be able to have a higher papilla in adjacent implant situation or implant and teeth situation. And on the right side, you can see that we use an S-shape design of the emergence profile, and also an anatomic proportion or dimension of the intercoronal triangle or space in order to gain and to manage the papilla aesthetically between 2 implants or 2 adjacent implants or an implant and a tooth. So literature is showing us that the S-shaped concavity of a transmucosal portion has a firmer connective tissue. So this is the design that we use also in the single tooth case. And it's not an screw retained crown, because the direction, the direction of the axis of the implant didn't allow that. And we will talk about that later on in a full arch situation case. But the S shape is there, you know, the zirconia in contact with the soft tissue. This is the work done by Stefano Inglese in a tooth implant adjacent situation. The happy patient, a very, very natural looking crown on implant. And this is a long term case. Another case, which is more interdisciplinary, shows us that missing laterals, where my orthodontist started to open the gap for two lateral implants. You know that when we miss the laterals, then we have lacking bone. So the first thing that we need to do is still a bone grafting, which we do after we visualize the smile and we plan the future teeth in the frontal area. We take a grafting method or an incision method, or at least an incision method, which is automatically not to disturb this the aesthetic of the soft tissue, because the patient has a gummy smile, and not only because of that. So instead of taking an incision which gives a recession, an intrasulcular incision, or on the right side an papilla sparing incision to have scars in 70% of these cases, we take a hybrid incision, look at the middle, which is sparing the papilla and going intracellularly only in the regions which we cannot deal with recessions. So therefore, we have a pleasing situation of the soft tissue afterwards, and having the 3D visualization of the future lateral teeth, and you see the bone grafting here in the planning picture. And now we have the bone necessary to place an implant in an anatomic position. The position of the implant is something that is dictating the aesthetic, and not only the immediate aesthetic, but the long-term aesthetic. And this is one of the conclusions of our preliminary study on aesthetic parameters on implants. So we notice then, if we place the implants in a depth which is 4 millimeters from the free gingival margins, the color of the implant is at 4 millimeters, and on the other hand, the buccal distance of the crest of the implant is 4 millimeters from the most buccal contour of the gingiva. That means bone plus soft tissue. Then, and we keep this distance at both implants, we have then at the end a nice aesthetic situation. This is the CAD-CAM made crowns and veneers on her frontal teeth. We have a pleasing situation, which after 2 years is absolutely the same. And this was concluded after 2 years, where we matched the Combin CT of the result, or after 2 years, with a new scan, which we saw before, and we see that the distance, that the parameters are the same. So if we have that 4 millimeters depth of the insertion, and maybe that is matching a little bit with Linkevich's concept, right? And also a buccal distance of at least 4 millimeters with the algorithm necessary, even if it's 1 millimeter of bone, 2, 3 millimeters of soft tissue, or the other way around. This parameter, this algorithm has to be respected, and then is a preliminary conclusion that we have constant, or that we have steady aesthetic result and stable result after a long time. Now, what happens in full arch navigation? I have to hurry up. In full arch navigation, we have the same steps of the digital planning and reconstruction. And as I said, we started a study on complete full arch reconstructions with immediate loading and see the algorithms, because those algorithms we were using also in the planning of all these full arch cases. Talking about FP1 situations, so mostly situations which are not, where we are not It's not necessary to raise the flap to open the flap. Then we start with the scanning, and this is just an example of the daily case which we do in the office. Scan, plan in Exocad 2D, then 3D is visualization of the teeth. Then the planning of the implants in the upper and the lower jaw. Implementing this walks-up, digital walks-up in the face scan in the same software, and because we register this movement, and this is a workflow which we do continuous and every time, this movement and this of the jaw will be transported in the provisional, in the planning, in the provisional, and in the final reconstruction. Planning of the implants, take care that the guide is supported by teeth and not only by soft tissue only. Always, it's possible to choose a guide situation where we support it by teeth. It's much more stable then and much more precise, not stable, but precise as the soft tissue supported. Then we go to the make chapter where we print the guides. We print the provisionals, and we have different methods of stabilizing or fixing the upper provisional in the best occlusal position. And then we go for the surgery, which is actually a very well organized procedure talked before with the team in order that the sequence of placement and the sequence of drilling should be the short as possible, and that minimize the time of the insertion. So upper lower jaw, it looks like this. That is why the surgical is the surgery is reduced time. This is the position of the implants in the depth, as I mentioned before, in the buccal position from the most buccal contour, grafting of the sockets where we have sockets, and this is the provisional which the patient has to go home. Another case is an older person which wants also fixed teeth in the upper jaw. What is special about this case? This case is conceived with two guides because we tend always, because we know from studies that the guides supported by teeth are much more precise than the soft tissue supported. We have one guide on the left side which is supported on the frontal teeth. Then on the right side we extract the frontal teeth, mount the guide on the lateral teeth with not lateral implant which we placed, and then we place the frontal one. We have a thin tissue, or actually the position of the implants allows, and the 4 millimeters which we have in the planning, and the provisional is made in advance in PMMA. This is the final reconstruction by tooth reconstruction, screw retained, and the happy patient. Another case is and the evaluation after 1-2 years shows that if the situation, if the position of the implant is respecting the algorithm of 4 millimeters, then the aesthetic is pleasing. So another case has short teeth. This is Susan, has short teeth, reduced occlusal vertical dimension. We increase the occlusal vertical dimension and plan the implant the way we did before, respecting the algorithms, planning the guide, planning the provisional, or manufacturing the provisional, this time with metal frame because the metal frame is given more stability in this case. Going to the surgery, and also grafting sometimes, internal sinus elevation, or you can use the Denza drills for internal sinus elevation. This is the final situation, and the patient with the final situation. We read the fascinating method of scallop guide, or the guide which is supporting supporting the provisional and the implant guide, the triple guide, as you can call it. Now, of course, the surgeries done with those kind of plannings are very nice, and they have the advantages that you can stack the surgical guide and the provisional on that first guide. But at the end of the day, we are about to search the precision of this concept, because it looks very nice and we can do also scallop, but we will see if by the evaluation of the multiple cases done with this triple guide, if the precision of the end at the end is the same as if we do with the one. So another case, which was one of the main cases where we learned a lot for the first study, is the 32 years cosmetician as a man who has a perio disease, where it's necessary to be all upper jaw teeth to be extracted. In the lower jaw, we maintain 7 teeth, which could be periodontally saved and stabilized. Then we have a desktop scan of the wax-up at that time, and a planning of the case, which has frontal teeth, a single teeth in the frontal area, small bridges in the lateral area. In the lower jaw, as I said, 7 teeth and the rest implant. Doing the planning, this is the moment where you use all the algorithms which we know already, and also the planning of the surgery mentally. You think about which are the teeth which you can maintain for the stabilizing of the guide. We think about the position and we plan the position of the implant after the algorithms. We do increasing of or grafting of the soft tissue in a minimally invasive way, like a pinhole technique or an envelope technique, if it's necessary. We plan how to do the open sinus elevation if it's necessary, in which moment of the surgery, and so on. So all the algorithms are to be set now, and we are working on those algorithms in order to be placed automatically through an artificial intelligence software. So we know that we need actually 2 millimeter soft tissue and 2 millimeter bone grafted inside or outside the socket, or and also 3 millimeter soft tissue thickness, soft tissue height, and keratinized tissue initially, right? And this 3 millimeter soft tissue is important when we want to have adjacent implant situations and papilla between 2 implants. Another algorithm and another issue which we have to take care of is the axis of the implant and planning of the prosthetic components of this reconstruction, because we used to say that the screw should come when the surgeon is good. The screw should come buccally, should be buccally. Now we know that from the study of Joseph Hahn that 80% of the situations are anatomically in a way that you have the screw buccally, and only with a tilted canal or a tilted canal or screw or a multi-unit abutment for a single teeth, you can switch the screw palatally. So that means that the algorithm of choosing implant design and an implant system is, if you want to have, if it's necessary to be done, the screw retaining palatally, then we need to have those components. The depth of the insertion is 4, and also the buccal dimension, the algorithm of 4 millimeters should be respected. So this is another algorithm in the planning. Then the manufacturing of the provisional is done in the beginning, in the planning phase. Flapless surgery, the second premolar will be maintained, and we go to the surgery, which has an actually very, very precise placement of the implants, which is not as precise as we think it is, with the discrepancies and the distortions that I mentioned before, coming from the added mismatching or discrepancies from the different technologies and matchings, but it's much more precise than the freehand, and this is a clear statement proven in the literature. We have the bony and the soft tissue situation optimum, so we don't have to add any procedures. We have a provisional after 2 days, which is improving at the moment the life quality of the patient, She has, though, to have a very balanced occlusion, which has to be done with, had to be adjusted with the sensor-based technologies named T-scan, because it's an immediate loading. Now, because we know that the intraoral scanner is not offering the precision which we need to have in full arch reconstructions, we go still analog for the impression, which is matched with the impression of the provisional, and this is the fuel, this is the base for designing the final abutments, which are made CAD/CAM with help of technologies based on artificial intelligence. This technology is invading and existing already in some of the technologies which we use, and are very useful because it's shortening the time and easing the concept. This is an example by this, like apparently, by the artificial intelligence used in a fixed implant prosthodontics. Is a recent article which we wrote together with Francesco Mangano, where the situations with a single tooth implant and the digital impression of by scanning of the implant is the base for producing a provisional abutment. Now, the provisional abutment will be scanned, right, and placed in a part of that software as an STL file. Now, when we scan the position of the hybrid abutment after healing, what the software does based on artificial intelligence is going and taking the right image from that individual person and matching it to the actual one. And at the same time, is able to precise, to create, to precise and to create automatically, to trace the margin line of the abutment independent of the position or of the shape of the gingiva. So that is an economic and a very short way of doing the final crown with the perfect margin of the gingiva or the margin of the abutment, because otherwise we would have to pour a model, make a crown on the model, and all this will lead to accuracy, lack of accuracy. So that means that our study is showing that we have a 45 microns accuracy using this method. Those kind of technologies should be used in all these workflows. So this is back to Asamine. We have the individual abutments with the margin of the abutments placed slightly below the gingival margin. Now, this which we need to know is also the distance between the margins of the abutments, the final abutments, which is necessary to be 3 to 4 millimeters in order to have the base for the papilla to grow. And this is a language and an algorithm which all technicians and all clinicians should know in order to be able to create the papilla. And that is why I say we learn from our mistakes. This is the situation after 2 years. This is Asamina before and after. The case is probably not perfect, but is a life-changing situation for her. And this is what we want for our patient. Stable situation in time of the bone and of the soft tissue by respecting the algorithms, by respecting the dimensions, but also by a recall, which is every 4 months for preventing peri-implantitis by eventually treating mucositis, and by a perfect adjusted bite with a sensor-based technology. And this technology is giving you with the precision of 25 microns and very precise values in full arch reconstructions, but also in full arch reconstructions purely on implant, but also values of implant time delay in the constructions when you have teeth and implant combined. So all these parameters you can read in the handbook for computerized occlusal analysis in dental medicine. All these steps, all this sensor-based occlusal analysis will be done in every step of the appointment. And this is also a base for this technology it will be subject of one of the subjects of the consensus conference of the Digital Dentistry Society in October by a multi-center study. Of course, we have other guides, which I showed you in some images before, and a fascinating guide is the sleeveless guided surgery, which has pretty advantages by being able to be sterilized, by having the visibility enough to do any other soft tissue procedure, and seem to have a higher precision than the sleeve guided surgery, being guided by the handpiece, and some canals in the guide which are driving the handpiece in the right position. So as I said, there are some advantages of this system. This is one of the cases which we did, respecting, of course, the same parameters independent of the planning software. We respect always the same aesthetic parameters of placing the implants, doing it through looking for the guides which are more and more precise. If we have to open the flap, then we use for the increasement of the soft tissue thickness methods and matrices, including PRF, to implement the soft tissue quality, and the amount or the thickness of the soft tissue which we gain was a subject of another study made with the University of Frankfurt with a form lab, and it's submitted for publication. We realized that using different matrices plus minus PRF, we get different additional heights to the tissue thickness, which is the most important thing actually in the aesthetic, long-term aesthetic success of the cases. So we have this situation after the healing, and this is the final result of the patient made with this guide. And in Baden-Baden, everybody wants really white teeth. Dynamic navigation is an other type of navigation which is not using guides. That is why we don't manufacture guides. The planning is the same as with any other software, and the placing of the implant is guided by a 4-dimensional target which we need to follow by the handpiece. When we go for full arch reconstruction, as in this case, we need a reference, we plan, and then we need a reference, which are the neighborhood teeth, or even a mini implant where the reference is. The advantage is that we can do spontaneously all procedures and which we need to do, like sinus elevation or even bone block, without any problems. Additionally, this is the situation of the final result, as you can see, with the movement, including the movement, the final restoration of the patient. Now, another advantage of this dynamic navigation is the reality that we can evaluate the precision immediately and the moment of navigation. The statistics are showing higher precision, of course, of the freehand, but there is a learning curve, which shows in the study that the more implant we set with this system, the more precise we will be in the result. But nevertheless, in the static and the dynamic navigation, we have in both differences in the accuracy of the implant placement, depending on the surgeon's experience. So it has also a learning curve as the freehand surgical placement. That is what we know now. Now, the high success of the reconstructions in navigation with immediate loading over 3 years is high, and it has some well-known parameters, and are using newest technologies as artificial intelligence too. So here are only a couple of them concerning insertion depth, algorithm of the position of the implant buccal palatally of 4 millimeters, as you can see there. The reality is we need parameters, new and actual parameters of accuracy, trueness, precision of the devices and of the matching, where we have big hope that artificial intelligence will help us a lot. We have this S-shape emergence profile, the finding, and a Z finding of the margin of the abutment depending on the soft tissue thickness. We have also the possibility to trace the line of the margin of the abutment. We have the dimension between the abutment distance. So those are algorithms which we know, and we know already have to be used in order to have in full arch reconstructions, and also in single tooth, a predictable aesthetic result. Now, of course, that artificial intelligence and machine learning is something that is really coming very fast, and also technologies like 3D, 4D, bioprinting, and we are working on studies concerning all these technologies. It's a new dentistry, but it has, as you see, advantages, well-known parameters, which give us already the possibility to offer the patient a predictable aesthetic result and to have the satisfaction. Nevertheless, there is a learning curve. There are still standards, values of accuracy, trueness, and application of the new technologies in the office. But that makes our work and our daily office so fascinating, and our profession. And that makes also our curiosity to move on, and our ambition to move on and to be curious to see what comes up and to implement it in the office also. That is why I invite you to be a free or an active member of our Digital Dentistry Society, which is offering you free and not free e-learning courses, exciting courses, informations, and help you to be connected with the new technologies and with the studies connected with it. We have also a strong relationship with the Frankfurt University in the Master of Aesthetic Dentistry. So if you want to go even a step forward in education, please do that. I would like to really thank you, Tianor and all the team, for this great initiative, spreading free information and knowledge worldwide. It's a fascinating world which we have to profit of. Thank you so much for your attention.
Thank you, Doctor. I'm going to go ahead and get our host back on here. All right, there we go. Okay. And Dr. Atala, could you kindly address any questions that there are, please?
I think they're not.
No, it's wonderful. Doctor, I have a question for you. What's your thoughts on the guys that is guiding the handpiece instead of the drill that you just mentioned? Do you think it's a little bit more accurate just because it's like the lever arm and it's guiding the handpiece itself, or not really? Not really?
I don't think that is more accurate. I know that is more accurate.
Oh, you know,
I mean,
right.
there are studies that are showing a higher accuracy,
which makes
as many other workflows and guides, Steve guided implant placement. That is what I can tell you. It's more studies needed. In anything that I say, it's the state of the art, state now in this moment. Anything else will come, and we are working on many other studies on accuracy of these guides and all the other workflows connected with this type of guide, or also with the sleeve guided surgery.
Perfect. With the error margin, how can you decrease it as much as possible? Are we leaning more towards thinner implants in the future, do you think?
Say that again, please.
For the error margin, what are the main things that in the future you will see or you think will help us to decrease it or dissipate it? Are we going more towards thinner implant in the future?
I don't think that you mean the reduced diameter implants.
Yeah.
Reduced diameter implants have their indications too, and their limits too. So there is an application of the reduced diameter implants in the supporting of the or in reduced bone situations where the medical situation of the patient or anything else is not allowing to do a bigger on the other hand, we use the conventional implants in the limit of the bone. I think now I understand. By talking, I understand your question. I mean that we use conventional diameter of implants and the necessary bone around it. So we don't reduce the diameter of the implant on the cost of the amount of the bone or soft tissue around. So we use the conventional one. This is the algorithm. But this is a very good question, actually, because it's
the future is
absolutely. So that means there is a limit where the stability should play the main role, and if enough bone soft tissue around it is okay. If not, we choose method with minimally invasive methods in the guided surgery to improve or implement the bony or the soft tissue quality. So guided surgery doesn't mean that we go flapless with any, that is exactly what I needed to say, what I want to say is to find the algorithm or the parameters which offer you the stability, the minimal invasive treatment, but at the same time, high aesthetic and long-term stability. Yeah, so that means we can even open the flap and make grafting. But the idea is, if we want to maintain a minimal invasive treatment, to use also bone and soft tissue grafting procedure, which are minimally invasive, not necessarily opening the flap. As I said, pinhole, tunneling, vista, envelope, smart technique. You have so many new things that are really applicable. Denza, yeah.
How often, or do you usually reevaluate the occlusion? Like after how often do you reevaluate the occlusion? So after you do the implant and adjust the occlusion with all the physiological changes with the patient and everything, do you reevaluate the occlusion, and how often usually you would recommend that?
Very good question also. Very good question. So the T-scan technology, I have to say it by the name because there are not so many in this field, is giving me the precise occlusion with a precision of 25 microns. I use it in the moment the patient comes. This is part of the scan chapter. Then I use it for checking the occlusion in the immediate restoration because it has to be balanced. Then I use it after reconstruction, 2 days after the placing the final reconstruction. And then I use it once a year.
Once a year.
Because we know that the causes of the peri-implantitis are infection plus bone loss. So in order to avoid bone loss, I need a very good adaptation of the occlusion. Now, I have to say that to tell just in two sentences the difference between the blue paper and the sensor. When you have the blue paper, you have the occlusion with blue points all over the place, but you don't see the intensity in every point. Having the sensor gives you the intensity in every point. Sometimes when you don't have a blue point, it doesn't mean that it's no contact. It means that it's too much contact. Yeah. And since we're working with implants, titanium-based, zirconia, EMAX, and so on, we need a much more detailed information and finer information about the occlusion because we have to avoid the misloading or the overloading and so on. So,
and the polishability of the crowns and the restoration differs with the markings as well. How much polished it is, yeah. Have you heard about the bendable implants on the research, where implants, abutment, and the implants are one piece and bending it one time only?
Yes. Are you afraid of it?
I'm interested to know more. What's your thoughts on it?
Yeah. So all the studies, since we are scientific, right? All the studies which are done, or not all. I mean, most of the studies are done with conventional concepts of implants. That doesn't mean that nothing else functioning. Yeah, but we talk about things or rules, parameters which are well known in the literature and which we can educate on. Now, out of the box is also the Bicon, the short implant, right? Because it has another design, is another religion. Out of the box is a one-piece bendable. Why? Because some parameters are not to be measured or are not to be taught or educated, because how you bend the implant, how often you bend the implant,
the biting occlusion itself, will it bend it,
and so on. How do you tap the bite in order, you know what I mean? So those are things, but it doesn't mean that there are not good concepts. This is one point. Second point, I never say never, because the things that are at some point you say no, tomorrow are the future. So yeah.
Very good. Beautiful presentation. I'm waiting for more questions. If anyone have anything, please start typing them down.
I'm gonna jump in here with you guys. I got
take a nap in the meantime.
It's a wonderful presentation. It was very thorough.
It's fascinating sitting here. I was relaxing a little bit, but wow. Doc, what would you say to someone that wants to start learning digital dentistry? I saw some inquiries, want to learn digital dentistry. What would you say to them?
Okay, so I think that as in anything else, the first step is education, right? And a structured education. Not doing a course with a scanner or technology Saturday and Monday start digital dentistry, or so you need a structured education from A to Z. This is actually what the Digital Dentistry Society is offering worldwide. So just get in connection. That was my message at the end of the presentation. Just register as a free member or even as an active member if you're more experienced, and take advantage of these possibilities of structured education. It's happening in every country. We're doing it also online. So go for it. This is actually my advice. And those educations are for all the team. This digital dentistry is an interdisciplinary discipline. Okay, it is same language which has to be spoken by the doctor, by the assistant, by the technician. We work more than ever together. And if somebody doesn't know the workflow or a parameter of the workflow, it's a huge mistake, which we cannot allow ourselves.
It's a new philosophy that we have to all adapt to.
Mm-hmm. Right.
Amazing presentation.
It's amazing to have Dr. Lerner here. She's also on a board of the Digital Dentistry Society, and one of her brain projects that came out of her brain, which is going to have a tremendous impact on our industry. Where can people get started with the Digital Dentistry Society, Doctor?
As I said, is first to in the moment they are registered, there is all the e-learning education there, or there are the literature is open access, everything, and connect us, because since we are present in 40 countries, we have our ambassadors and leaders in every country. They are offering also that education on a national basis. So that is how it should be approached.
That's wonderful. Well, with all the accuracy of digital dentistry and the way you conduct your entire career with precision, we are almost at 60 minutes.
Time flies.
So I like to sincerely thank you on behalf of all of our colleagues for donating your time and your contribution to the peer-to-peer project that has expanded across the world. And thank you for joining us today, Dr. Lerner.
Thank you for spreading the legacy of education, Dr. Atala.
It's a great pleasure. It's a great
pleasure. That's the one thing that brings us all together, the education and knowledge and information. All right.
And
With that
hopefully we'll
said,
see you
Thank
soon
you.
here. Thank you.
Stay
Thank
safe
you.
all everywhere.
Thank you.
bye-bye, Germany. We'll see you next time.
Bye, Dr. Lerner. Honor, pleasure.
Bye bye.
Pleasure.
Take care. Same
Thank
here.
you.
Bye.